you can dial in, and the number is there on the screen, and the team will also be putting it into the chat there for you. So any problems with your audio, do dial in and you should have a better sound over the telephone. Just moving on, Mary, if that's okay. Just let you all know that today's session is CPD accredited. 2 CPD points have been awarded from the RCPI and 2 CEUs from the Nursing and Midwifery Board of Ireland. These apply to attending the live webinar, and if you need to have a certificate of attendance, please email the Open Disclosure Office at opendisclosure.office@hsc.ie and we will issue a cert to you. Just to also welcome our 2 interpreters today. We have Dawn and Ayla, who are supporting us as ISL interpreters, and it's very important, and we welcome you both here today, that we have this additional support for our webinars. And in addition to that, we do have a closed captions option, which is text that will appear on your screen to reflect what is being said by the presenter during the webinar. And to enable this function on your device, please click on Show Captions on the bottom left on your screen, and then the narrative will come up as it is being presented for you. So I'm going to hand you over now to our Assistant National Director, Lorraine, who's going to introduce our wonderful speaker today. So over to you, Lorraine, and thanks everybody. Enjoy the webinar.
Thanks, Angela. Hi, everyone. Welcome to this webinar. I'm delighted to introduce Professor Eva Doherty. She has a very eminent resume. So just to give you a few highlights, she's a chartered clinical psychologist, and she's the Director of Human Factors and Patient Safety Training for surgical, ophthalmology, emergency medicine and radiology trainees at the National Surgical Training Centre at the RCSI. She joined the RCSI a number of years ago as a psychologist and lecturer in the Department of Psychology. She then moved to Graduate School of Medicine in 2006 and then joined the National Surgical Training Centre in the Department of Surgical Affairs in 2009. And in 2010, she introduced a new academic master's in Human Factors and Patient Safety, which is now an interdisciplinary online postgraduate diploma and master's program. She is the Irish representative for the International Association of Communication in Healthcare and co-chair of the advisory committee of the organization. And she is a chartered and associate fellow member of the Psychological Society of Ireland and a member of the Communications and Media panel. She's also a chartered member of the Associate Fellow and Associate Fellow of the British Psychological Society and Principal Fellow of Advanced HE, so formerly the Higher Education Academy in the UK. She's chair of the Respond Committee and advisor to the National Healthcare Communication Programme of the HSE, and she continues to practice as a clinical psychologist and conducts a number of pieces of research and supports various research topics, in particular on communication and healthcare. With her over 30 years experience teaching at both undergraduate and postgraduate level at RCSI, she continues to strive to build healthcare professionals' resilience. So many accolades there to Eva, but I think it's really, apart from all your achievements, I think the influence and impact that you're actually having on the healthcare service is quite profound. We know that you're very passionate on the topic. You were referenced in a short snippet by Dr. Emily Connor yesterday, very recently, who was speaking on the Brendan O'Connor show on the radio, and the impact and the challenges healthcare professionals experience. And she really spoke, praised your program and the training that you deliver to help build that resilience. So we're really, really grateful that you've taken the time today again to speak to us about this important topic. So over to you, Eva. Thank you.
Thank you so much, Lorraine, and thank you for that wonderful introduction. So it's a case of follow that now. I'm just going to share my slides for everybody, and so here we are. I hope you're able to see them okay.
Yes, we can see.
Great. Okie dokie. So so caring for staff after a serious incident, or actually, you know, any incident, I think, you know, can cause stress for somebody in healthcare delivery. And then it's, you know, it's been called second victim, and it is quite a recent concept, and it's something I think that all over the world there's a lot of work to be done on yet. And people are toying with the phrase, you know, should it be called second victim? Should it be called second casualty? Some people don't like the word second victim, and we'll talk about this. So just to give you a little bit of context, you know, if this is your first time on these webinars and you haven't heard me before, so as Lorraine very nicely said there, I'm having trouble moving my slides now. Oh yeah, here we go. So yes, so I direct the human factors and patient safety. So what exactly is that when it's at home? So we actually we're just about to hopefully publish this. We've worked out clearly defined competencies for all our trainees and even non-trainees too who come to our programs. So I won't list them, you can see them all there. And that's essentially what the program addresses. And also we assess their communication and negotiation skills in years 1 and 2, so that makes it quite high stakes. And it's a very long program. It goes over 8 years, so it's quite comprehensive. It's pretty well unique in the world, actually, and it's partly because we're a small country, we can do this. And we also have CPD training for people not on the training programs. So that's just to give you a bit of background. Lorraine mentioned our academic program, and that's open to you all. And if you want to scan that QR code there, it'll take you straight to the place on the website. We're accepting applications at the moment, and you might like to have a look at that. And essentially, it's based on the materials that we know worked with the trainees, and we've mapped it over and made it an academic program. So check that out if you're interested. We also have podcasts you might like to check out as well. And in fact, our most recent one is to this point, serious incidents, but this one's from the patient's perspective, which of course is crucial. And this was a very tragic event, a never event, where somebody had surgery to take their stomach away because they thought there was malignancy there, which turned out not to be the case. And so you might like to hear the patient story, and Alan O'Gorman, we're very grateful for him for talking to us. So you can check that out as well. Safe and Sound is the name of this series. Okay, so what do I want to do today? So I want to really talk about the concept of the second victim, second casualty. Again, you know, the door is open here about what we end up, you know, calling it in Ireland. And I've heard some feedback from around the country that people are not mad about the term second victim. That's certainly something that people internationally are discussing as well. But really, I want to focus on the emotional aspects. And I'm very conscious of the fact that, you know, I've so many of these described on the slides coming up, but it really doesn't convey the depth of suffering I think that a healthcare worker goes through when they are involved in an incident. It is just not what you all signed up for. You did not come, you know, to study for whatever profession you're in, you know, with the idea that you were going to be involved in anything that resulted in harm to a patient. Quite the opposite. And I know, I just want to say from the beginning, you know, that it's so hard to convey, you know, the emotional side of this and how devastating it is, just on PowerPoint slides. And then I want to tell you a bit about the evidence about what we know so far about what supports people in this situation. And I know the next webinar is going to go into this in more detail, so you'll actually be able to find out what you know, what supports are out there for you. So that's definitely going to be really important to tune into. And what I want to tell you about is that I'm really lucky to be part of a UK-based initiative which has been led by the Royal College of Surgeons in England. And they have opened their arms to us, if you like, and included us in a collaborative which is looking at setting up a support program it's initially just focusing on surgeons, but what we're hoping is that it's going to extend out to everyone once we get it right. And we have a pilot hospital identified here in Dublin that we're going to try it out with and train other surgeons to have once-off conversations with surgeons when they're involved in something that goes badly wrong, because we know that as a lot of healthcare professions, people tend to bottle it up. They don't talk about it. They're so embarrassed and feel so awkward, and they suffer in silence, and we want to address that. So a lot of the slides I'm using, here's another one, are shamelessly taken from the work from the Royal College of Surgeons in England, because the psychologists there are absolutely fantastic, giving me permission to use their slides as I wish. So I have a few of them here in the presentation. And in a way, I think it's really only when you hear people's stories that, the real depth of all of this becomes so clear. And so, what I'm going to ask now is, if we're to have a breakout discussion and I was to break you all up into twos, and if you were to tell each other about a mistake that you feel okay to talk about, and if you were to tell the other person what happened, how did it affect you, and how are you now? And I just want everybody to just reflect on that, because none of us escapes from this. We've all been involved in something that has gone badly wrong, and just have a think about that. And the good news is, I'm not going to put you into breakout rooms. I can feel maybe some of our support team in the background are thinking, wait, she never said anything about a breakout room. I'm not going to put you into breakout rooms now, but I just do this sometimes to just help us to actually reflect firsthand what it feels like to have to talk to somebody about something that went wrong. And maybe you could reflect on, what you just felt at the thoughts of having to do something like this. Did you feel awkward? Did you feel anxious? Did you feel embarrassed? Maybe you felt a bit of relief, oh, actually, do you know what? I would actually like to talk about this. Maybe you felt annoyed. Maybe you felt, go on, we're not going to do this now. Just reflect maybe on the emotional response, because that will tell you so much about how, the effect that it has had on you. And Albert Wu is a name maybe known to some of you. He's certainly been here at some safety conferences in the past and has spoken. And I just love this quote, and I very rarely read out what's on a slide, but I think this one is worth it to read out. He said, while patients are the first and obvious victims of medical mistakes, doctors are wounded by the same errors. They are the second victims. Now, he was talking about doctors, but this applies to all healthcare workers. Virtually every practitioner knows the sickening realization of making a bad mistake. You feel singled out and exposed, seized by the instinct to see if anyone has noticed. You agonize about what to do, whether to tell anyone, what to say. Later, the event replays itself over and over in your mind. You question your competence. But fear being discovered, you should confess, but dread the prospect of potential punishment and of the patient's anger. And I think that just so well captures, what goes on in people's minds when something like this happens to them. So it's not going to be a surprise to hear that when you look at the literature, as I have done for this talk and have done on a number of occasions, the same things come up over and over again. And anywhere from 40 to 60% plus or more people, depending on the study that you read, will display these emotional reactions to being involved in something, critical in a patient safety incident. It's very distressing. The anxiety is very significant. The guilt is overwhelming. It can very much lead to depression subsequently and just feeling so helpless. Lots of people leave their profession. They never come back. Probably lots of you know of people, that have reacted that way. People will suffer with sleep problems. They either can't get to sleep, they keep waking up, or they just want to sort of sleep and almost, anesthetize themselves, from what's happened. Very much the symptoms of post-traumatic stress disorder. are come up in the literature with flashbacks, replaying the event over and over and over. That's our minds trying to reverse it, you know, trying to make it so that it didn't happen. And a lot of people will turn to substances or addictions to try and again relieve the emotional side of it and how it feels. So again, I'm so conscious of the fact that this is a list of emotional consequences, but in no way does this capture the depth of distress that people feel. And I just want to say that again. The College of Surgeons in England have conducted some very nice qualitative research, and I think these statements probably epitomize a lot of what you all might feel. You know, things like, I don't understand, you know, the way I'm feeling, I shouldn't feel like this, my shame, my anxiety, guilt's getting in the way. There's barriers out there with my peers. You know, for surgeons, showing vulnerability is not okay. Speaking out is dangerous. I think lots of professions will identify with that. I'm worried about what other people will think of me. I don't know where help is, where to go. Talking to superiors or others is too difficult. It's not going to make a difference. When I do talk, I don't get the response that I need. And I think that probably epitomizes maybe a lot of what all of you will feel. This doesn't just apply to surgeons, although that's where the research was done. One question that is relevant, particularly to surgery, I think, but also, you know, medicine generally, nursing, you know, does it matter if whatever's happened is an error or a complication? You know, so could it be a complication perhaps of some kind of treatment? Does that make a difference? And, you know, errors are preventable events arising from shortfalls in the standard of care expected, whereas a complication is an acknowledged risk of medical and surgical care. When you go to the literature, it does actually seem that the psychological impact of an error is greater than the psychological impact of a complication. Now, it can depend obviously on degree and lots of other factors, but it seems to make a difference. And so that's something I just want to introduce into the conversation, if you like, because I think sometimes we blur those boundaries between what's an error, what's a complication, and in fact it can be quite grey. Okay, now in terms of what helps. So again, this is a list, easy to say, hard to actually make happen. The first thing that is so crucial, and I think we have so much work to do on this in Ireland, and I'm going to say a little bit more about it, is the safety culture. We have to have a no blame culture in our healthcare services if we are going to get anywhere with supporting people. And not only supporting the patient and their family, but also supporting the healthcare workers. It's just a no-brainer. We've so much work to do on this. The support from the organisation is crucial. It comes up again and again and again in everything that you read. There has to be a supportive reaction. You know, it is a cliche, but nobody gets up in the morning, you know, to do harm. They just don't. And so the idea of blaming people and punishing people is just, it's back in previous centuries. It doesn't belong in the 21st century. One thing that has great support in the literature and very good evidence, and I know the HSE are engaging in these, are after action reviews and various different kinds of debriefs. So you can have, you know, what's known as a hot debrief, which is like, you know, straight away after something. You can have a cold debrief, which is maybe, you know, after the time. And I'll say a little bit more about how do you do an after action review in the next slide. Peer support, family support, lots of good evidence that this is really effective. This is why we're engaging in this new peer support initiative, which we're hoping, you know, someday will roll out and be part of, you know, the culture of how the organizations respond. And finally, then, you know, the individuals need to have access to psychological first aid, which is a phrase that came from the pandemic, which I really like, and counselling. The interesting thing about that, just to say something about that last one there, is, and this is certainly something that's part of the Assist Me model, which is advocated by the Open Disclosure Office, which I'm sure a lot of you will be familiar with. It's not about giving everybody counselling, sort of saying, right, you all have to go for psychological support. We know especially from what happened in 9/11, we're much more well informed about that. We know that, just marching in and giving everybody psychological support actually can make some people worse. You really have to monitor people and see how they're getting on, and are they able to access resources? Have they got, maybe even the personal resources inside themselves to cope, to recover? And if they're struggling with recovery, then you come along with your psychological first aid and your counselling. But it's not a kind of a one size fits all by any means. After action review, what is that about? Some of you will hopefully have participated in this process, and it's guided by these 4 questions. So what did you expect to happen? So you have a conversation about that with everyone. What actually happened? You have a conversation about that from everyone, and everybody can have different perspectives, on both of these. Why was there a difference between what you expected and what actually happened? That is such a fruitful conversation. And finally, and so importantly, what can be learned? And, a learning organization, we know, is an organization that is going to be safer. There has to be learning going forward. What happens if, if support doesn't take place, if we don't have these systems that I've just described in place? Again, this is a nice slide from the College of Surgeons in England. We know that adverse events, safety incidents are associated with burnout, with more complications, that, there's a real impact socially on the person and how they function as a team member. They might need retraining. We know that people are going around somewhat invisibly burdened down. This idea of an invisible rucksack just burdening them and pulling them down the whole time and making things so difficult. We know that it can lead to absenteeism, to the notion of presenteeism, to capacity issues, to impacts for the climate of psychological safety. We know that clinicians who have been involved in an adverse event are more likely to make a subsequent error. We know that it has implications for the quality of interactions with patients, with the ability to demonstrate compassion. And we know that there's just in terms of surgery itself, but it applies to other things as well. There can be an impact in terms of the timing of surgery going forward and the decisions that people might make. So lots of impacts here. There is a massive ripple effect, if you like, if we don't have this kind of support. And it's great that the HSE is prioritizing all of this now. So the idea of psychological safety, which I'm referring to, if you're wondering as a leader, and it does come from the top down, and we are all, in ways, you are all probably leaders. You all have people under you and with you that you work with. And so leadership is important for all of us. We know, though, that if you want to have a psychologically safe little microcosm around you, how do you do that? You need to be curious and humble and non-blaming. That's hard to do. It's easy to say, it's hard to do. You have to really employ your emotional regulation abilities when something goes wrong so that you don't lose the head. And that you control your anger and your irritation and your frustration and your impatience. If you want to hear a little bit more about emotional intelligence, which is what this is all about, I talk about it in some of my previous webinars that you can check out on the Open Disclosure website. So it's difficult to take on an approach of curiosity when something goes wrong, but it's so vital and important. perspective taking. We know that leaders who encourage psychological safety, they're very good at appreciating other people's point of view. And again, that takes a paradigm shift to be able to do that. They also prioritize opportunities for team reflections, for drills, for huddles. More and more of these are happening in Irish hospitals, which is great. Leaders who promote psychological safety, they pay a lot of attention to the social contact between the team members. They organize coffee more times, birthday cakes, nights out, all those sorts of things. They're not a luxury, they're actually a necessity towards better team working. And they are committed to the importance of monitoring the well-being of others, like I was saying before. So they're good at keeping an eye on everybody and kind of going, do you know what, I think so-and-so is maybe not coping. I think we need to bring something in to help them. And if you want to read more about this, Amy Edmondson is probably the best known name associated with this. She's got some really nice TED Talks that you can check out. So what I want to do now is just play a short 5-minute video of Sidney Dekker, who is a psychologist. He's based in the US. He's also Australian, and he was born in the Netherlands. So he's multinational. He's a real patient safety advocate and has written a lot about supporting people who are involved in a serious incident, and he speaks really well here and better than I can, and I just thought you might like to hear somebody like him talking about this. He's written a great book on it as well, and a lot of other publications as well, if you'd like to check him out.
My name is Sidney Dekker. I am a professor at Griffith University. Let me tell you about a nurse. She was a long-time practitioner in a children's hospital. And then one day, a patient of hers dies of a calcium chloride overdose. The nurse is blamed, suspended, and fired. Her license to practice is revoked. Afterwards, she reportedly cried for weeks. A carer and a healer at heart, she not only lost a job, a livelihood, she lost an identity. Her psychological health deteriorated. She became increasingly depressed and isolated. And then 7 months after the patient's death, she killed herself. Now the patient, the child, and its family, in this case, would be the first victim. The second victim is the nurse. Second victims are practitioners who are involved in an incident that harms or kills somebody else or has the potential to do so, for which they feel personally responsible. Second victims are not limited to healthcare. I've met second victims in air traffic control, in airliner cockpits, in process control plants, in the police, in firefighting. And two things tend to set them apart. One is trauma-like symptoms. These include hyperarousal, re-experiencing phenomena such as dreams, intrusive thoughts, flashbacks, and avoidance behavior associated with the situation that made them into a second victim. And then they typically have feelings of intense guilt. Even if they themselves are capable of pointing to all the factors in the situation that contributed to the bad outcome, they will still feel guilt because they are responsible practitioners and because somebody else put their trust in them. Now, things don't have to go badly for the second victim. I know of 2 pilots involved in a large accident that killed over 80 people. And through the pain and the trauma and them losing their jobs and being criminally prosecuted in a foreign country, these pilots are flying today and with another carrier and thriving. Interestingly, the intensity and severity of the outcome is a very bad predictor of how things might go for the second victim. I know of another pilot involved in a pretty bad accident, not of his own making. All 129 occupants of that airplane basically walked away He did too, but he never flew again. The main determinant for how things go for a second victim is community, is social support. The mother of the nurse who committed suicide later commented that her daughter had run out of coping skills. But I wonder, was it the daughter who ran out of coping skills, or was it the community that loaded too much onto her shoulders to cope with? Was it the community that offered too little support in carrying the load? How an organization, how a community deals with a second victim says a lot about how they view safety generally. If they dismiss a second victim, if they push the second victim out of view, then that signals fear, anxiety, denial, a lack of a willingness to learn from failure. In that sense, I believe there is a very important link between the resilience of a second victim and the resilience of the organization. So what should we do? As an organization, you want to make sure, first of all, that you have mechanisms in place for psychological first aid. That is, after an incident, be able to take the second victim off shift and make sure that they can recover to a level of psychological and physiological functioning that is relatively normal. Then empower the second victim. Make sure that you debrief them extensively on what may come next, on what their rights and duties may be in the wake of the incident. If they want to, you may even want to involve them in the investigation, rather than them becoming a passive recipient of the end result of the investigation. You can make them an active participant and contributor, because they too will often be acutely interested in finding out how things could go so wrong. And finally, you may want to think about organizing or facilitating an encounter between first and second victim, but only if both are ready for that. Now, it may be a good idea to have such processes run by peers, those who do the work of the second victim, who know intimately its messy details, and not managers who, after all, can create career jeopardy for the second victim. And finally, make sure you don't automatically medicalize or pathologize second victims. They feel what they feel, they suffer what they suffer, not because they are sick, but because they're human, like you and I.
So a very passionate plea there from Sidney Decker, and I think he, in that very short video, I think he has described, some of the key concepts and directions we should all be going in. And, the College of Surgeons in England are recommending the exact same thing. They're saying that, our resilience, our well-being, our processes that arise from connections between us. It has to do with our relationships with each other. That is coming out in the psychological literature in lots and lots of arenas as being so critical. It's not about just within us, it's between us. It's the relationships between us all. That's how we get resilience and well-being. That's how we recover, and that's how we do well. So I'm going to start finishing up soon, but I want to just say a couple of words here about this notion of what are we going to call it? Are we going to call it second victim? Are we going to call it second casualty? And there are kind of pros and cons. I think the advantages of calling it as a second casualty is that if we call it second victim, it's kind of suggesting that the harm was unavoidable, which is going against the basic principles of healthcare safety. Like, we're all invested in improving patient safety because we believe it's possible to do. We're struggling with it, I have to say, and have been in the last 20 odd years since the report to Err is Human came out in the US 22 odd years ago now, and we haven't really gotten very far with the statistics, but But, you know, on principle, it should be possible to make healthcare more safe. But if we use this phrase second victim, it's almost like saying, you know, people are saying that it's kind of like saying, well, that harm was unavoidable. The other point that the literature is making is that using that term second victim is kind of taking the spotlight off the actual victim, which is the patient. And, you know, we can never lose sight of that. And so for that reason, people are saying, let's switch it and let's call it second casualty, because that acknowledges the real emotional toll on the healthcare worker, very importantly. And it still isn't absolving people of accountability or diminishing the primary victim, you know, who is the patient. So I'll leave that with you, and people might like to, you know, discuss that or have thoughts about that. And there's 2 significant publications that have appeared in the last few years on this. Certainly here in Ireland, this is a presentation which Saoirse O'Mara, you can't see her name there, she's an SPR in neurology, and she asked me to support her research and work looking again at surgeons, but they are adopting the phrase second casualty. So that's an initiative that is going on that led to the support program I was talking about earlier. So it's wide open at the moment, obviously. I want to start to close up now with some 2 really important quotes, I think, which again maybe nicely summarize, you know, what I'm trying to convey in this presentation. This one comes from Yu et al., who is a doctor, and he said in a seminal paper, no other profession that demands elite performance has devoted so little to the well-being of its practitioners. And I think, you know, what he's thinking about there is, you know, the amount of work that goes into managing the well-being of elite athletes, you know, in the military, in, you know, any of those high risk industries that you can think about. And in healthcare, you know, we take it as a given. Doctor, heal thyself, if you like. Healthcare worker, heal thyself. And we do need to, you know, not forget how much support people need. And also the very famous quote of René Lariche, who is a famous surgeon from the First World War mainly. He said, every surgeon carries within themselves a small cemetery where from time to time they go to pray, a place of bitterness and regret, where they must look for an explanation for their failures. And it's not surgeons that carry that with them. I think it's all healthcare workers have that little place in their mind where, you know, all the terrible things are lodged that from time to time they go to. And I think then, you know, I think part of this whole picture is the conversations that you have to have with the patients and family, because I think when things go wrong and then the conversations go wrong, that just adds to the whole injury. And so, you know, I am a huge communication advocate, and I'm happy to speak to that. And I have a couple of other slides in the presentation which you can look at, which just summarize some of the key skills, but I'm not going to go into them now because I've gone through them in detail in previous webinars. So if you want to go back and have a look at those, please do, and refresh yourselves about what are the key skills, the non-intuitive ones, the ones that, you know, we didn't learn since we were babies, but the ones that make massive, massive difference to these really challenging, difficult and emotional conversations. And that's it. That's the QR code again, if you're interested in that diploma, and I'm really happy to take questions or to have some discussion on this. Thank you.
Thank you very much, Eva. I've just gone onto my telephone here because of sound issues. Can you hear me okay there, team?
Yeah, perfect.
Yeah, yeah. So listen, thanks for the fantastic presentation as usual, Eva. And as Lorraine said earlier, this is a topic that's very close to our heart in the open disclosure team. And indeed, the fifth essential element of open disclosure we always talk about and have always talked about is the need to provide, support for staff in the immediate aftermath and on a continuing basis after, patient safety incident has occurred. Eva, we were interested in the piece you said around complications versus error. What is the literature showing around that? Just some of the detail around it, because obviously our open disclosure policy, we talk particularly around patient safety incidents, but we also talk about the need to have that really good communication skills following an error or following a complication. So, is there anything coming up in the literature about that? Does anything significant pop to mind?
Yeah, well, I mean, as I said, the evidence does show that the psychological impact for practitioners is greater if it's an error rather than a complication. And, that makes sense. I think it's probably, like in my own experience in our training programs, what I notice is that it's kind of easier to rationalize in one's mind when a complication happens. So let's just say if I stick in the surgical arena, which is probably what I'm most familiar with, though I'm a psychologist, so excuse me if I get some of the terminology wrong here. But let's say there's a leak, from an anastomosis, that was executed really well. So it's not because there was an error in the actual, stitching or stapling itself, but the leak has happened anyway, which is a recognized complication. The difficulty can be that, for the practitioner, that's kind of reassuring. Well, this is a recognized complication. We know that this can happen. And I think that helps with coping. However, for the patients and the family, the result is the same. The leak has happened. The consequences are the consequences. Hopefully, the person has survived. And obviously sometimes that's not the case. So sometimes I think for patients and their families, it's kind of academic, to use that word, whether it's an error or a complication. Do you know what I mean? So I think we just have to be very tuned in to the different perspectives of individuals here. There's the healthcare workers' perspective, the nurse's perspective, the doctor's perspective on a complication. But I think for the patient and their families, I'm not sure how relevant it is. I mean, it's important, obviously. It's important for people to be well informed and to appreciate this is a complication. We were told about it in the consent. Of course, we didn't think it would happen to us. It is after happening now, et cetera, et cetera, et cetera. And to be, very well informed about the fact as to whether it's a complication or whether it's an error. The other thing is, though, is that, and there's a great podcast on this in the College of Surgeons in England, if people want to check it out, where two surgeons are actually talking about how grey this can be. So sometimes, let's say, a clot, say post-surgery, might happen anyway as a complication, or it might happen because the prophylactic drug wasn't administered. So the same result can be, as I say, result of a complication or an error, and there can be quite a bit of overlap here, and sometimes I think that can get fudged. So I think we have to be really careful about being very explicit with all of that. I'm very conscious that I'm a psychologist talking about this. I think a nurse or a doctor or a healthcare professional would probably be better speaking about the details here better than me. But certainly from a psychological point of view, it seems that the psychological impact of an error is worse.
Thanks very much, Eva. You were talking about the work you're doing in the UK, and you're going to Paddington as Dublin Hospital. Can you talk us through what that might look like, and in relation to, what will be different about it in relation to what's happening at the moment across our health service?
Yeah, well, it's very clear at the moment, and again, we'll just stick with surgery because that's what I'm in emergency medicine as well. I know about the most, and I think, you know, maybe other professions have better support systems. Maybe the nursing profession has a better peer support system, or allied healthcare may have better support systems. But certainly in medicine, the support systems could be a lot better. You know, it's very clear that most doctors, the majority of doctors, do not go for help. That has certainly come out in that survey that our SPO Research America conducted. They tried to cope with it themselves. They didn't talk to anybody. If they spoke to anybody at all, it was more likely to be in their family, their partner. And yet there is such great evidence, particularly coming from the US, that having a well-established peer support program that automatically clicks in when something happens it can be so effective. There's really good evidence to support this now. So what we're wanting to do, and this is an initiative that has been started up by a urologist in South England. Kevin Turner is his name. And he has enlisted the help of two fabulous clinical psychologists, one from Bristol, who works in the area of staff support, and the other from Bournemouth University, who's conducting the research. And together they've put together a really good training package and support program of online webinars. Then there's face-to-face seminars. I was at one last week in London. It's really, really good. To set this up, so they're going about it, you know, the right way. And so we're lagging behind a little bit, but we're just starting to initiate it. We're actually having our first orientation meeting with the surgeons who have signed up to be the supporters. We're having that meeting this evening, and it'll be my job to you know, present the psychological side of things, although there is a psychological a team of psychologists in this particular hospital luckily, and they are coming on board, and I've been in touch with them, and they're all up for it, which is brilliant. But what we want to keep it quite well defined. It's not, you know, it's not, people need to be very clear about what they're signing up for. So what we want to do is we want to train the surgeons initially, but we have anaesthetists interested and involved as well. Anyway, we'll figure all this out, but we want to train people to be comfortable and to know how to have an initial once-off supportive conversation with their colleagues when something happens. And then a follow-up conversation as well. So it'll be really training them to know how to have that supportive conversation, because it is a skill in itself to do that.
Eva, I think that ties nicely into the Assist Me document, you know, that we have developed in the Open Disclosure team. And I suppose one of the things we were looking at was the RISE program in Johns Hopkins Hospital as well, where it really focuses on that peer response, you know, the peer support piece. And I think, you know, to even extend that Assist Me program even a bit further, digging into some of the detail, as you say, of having those first conversations and how to support a colleague, what are the good things you can say, what things should you avoid saying, the kind of language I think is very important there as well, so that even like our conversations with patients, that we don't do or cause further harm to the staff involved as well through the way that we communicate with them. So I suppose for anybody who's joined us today who isn't familiar with the Assist Me model, I think that the team have put the link to it into the chat function there. And this little booklet we developed through the program, it is being used now across the world. We get actually permissions sought all the time for people to use it. So do download it and have it in your service, because it does give you very practical advice. Eva, just in relation to, sorry, do you want to come in there, Eva? Yeah.
No, I was just going to say, I just think the Assist Me model is so clever, because, you know, it's such a nice mapping over of the Assist model and making it relevant for, you know, for the healthcare professional. It's just so clever. It's brilliant.
And I suppose like we need to make staff more aware of the really fantastic services that there is available for staff through the HSC, the Employee Assistance Programme, the Occupational Health Programme, the Health and Safety Programme as well. So and our webinar next month, we're going to be looking at, some of the resources that are available and looking at the manager's role in supporting staff as well. And some of them just, I suppose like extending some of the discussion that you started today, Eva. I suppose, Eva, if I was to ask you what recommendations you would make to improve the current approach to staff support in our health service, what would be the key things you would say?
I'm gonna if a fairy godmother came down and gave me one wish, I would say work on our psychological safety. I really like everything, like everything else will fall into place. Do you know what I mean? Like I really think we've got a lot of work to do with this. We really have to stop blaming each other, stop being hostile to each other when something goes wrong. We've got to do something about our staff morale. We've got to make it, we've got to make our healthcare delivery centres nice places to work, places that people want to come to work. And I wake up in the morning and they think, all right, I'm going to work today, yippee. We've got to, I think, really psychological safety. I would plumb for that. I just think, and we all have responsibility for that. We all can adopt two different ways when something goes wrong. We can start giving out to people and getting really angry and frustrated and irritated, or we can adopt curiosity and regulate our own emotions. And it's not about letting people off the hook. It is about accountability. It's not about responsibility, though. There's always holes in the cheese. There's always holes in the system that explain why something goes wrong. And we've got to stop punishing the people on the sharp end and making them feel bad. They did not set out for this to happen, whatever it is.
Agree with you absolutely on that, Eva. I can't see any questions in the chat team. I hope I've missed anything there. But Eva, just one last thing I'd like to chat to you about is like the impact of the media on staff as well. That can be very difficult when there's something that's high profile and, services and staff are named in the media. The impact of that on staff is phenomenal as well. I don't know if you have any comment to make on that.
Well, you see, that just intensifies it all. If we had the psychologically safe culture in our organizations, we could probably withstand the media attention. It would be a buffer. But, the media make it worse because they're after a good story. They're after headlines. They're after, shocking statements. That's their business. That's what they do. And unfortunately, it's all about naming and blaming. Psychologically safe cultures, don't make for good headlines, do they? So, so they make it worse. No doubt about it.
Yeah, and thank you for that. I'm just going to go back to team there. Is there any questions that have come in that we haven't covered, team, or does that seem to be everything?
Yeah, I think that's everything, Angela. There isn't anything additional into the chat.
Brilliant. And just Eva, there is a lady who's put her name into the chat for you to contact her who worked on a similar project in the West who's interested to chat to you. So we'll send on that email address to you, maybe so you can make contact. Yeah.
Oh, yeah, great. All help gratefully received and experienced, definitely.
So Eva, just once again, just to thank you sincerely. You've been such a support to this programme. You come on in your own time to do this, and the amount of effort you put into your presentations, we know that a lot of preparation goes into it. So just to that we really acknowledge your time, your expertise, and your kindness, and always being here and being such a wonderful communicator and teacher for us all and educator. So just from all of us in the Open Disclosure Office and the management team, and from all our attendees here today, just to express sincere thanks to you, and we look forward to future presentations from you as our programme kind of continues. So we'll just move in, and while we have Eva here as well, I just wanted to let you all know about a podcast. So Mary, if you wouldn't mind moving to the next slide here. So we're delighted to launch a new podcast episode from our All-Ireland series, the Walk and Talk Improvement series. And in episode 15 of this, Juanita Guidera speaks with Eva on the role of perfectionism in the workplace. Eva chats with us about how perfectionism is in the extreme can result in burnout, reduced job satisfaction, and compromise patient safety and care. So that podcast is being launched. We're just kind of officially launching that now today. And I don't know, Mary, can you move the slides? Maybe I'm not seeing them there at the minute, but there is a link to that podcast there as well. There we have it there. So there is a QR code there, and as I say, we can send that all out to you in the post-webinar information, which you'll all get. So we will be sending a copy of today's presentation to all attendees, and also the recording will be available on our Open Disclosure website. So just moving on, thank you very much for that, Eva. I'm really looking forward to that one myself. I'd also bring your attention to a podcast that Margaret Murphy made recently. Margaret is our wonderful patient advocate here in Ireland and a member of Patients for Patient Safety Ireland, and her recent podcast on her experience and about open disclosure and the importance of open disclosure, and she speaks to the area around staff support and the impact of the incident on the staff involved as well. So I really would, I think if everybody could listen to that podcast, we wouldn't have to do a lot more training around open disclosure because it speaks to everything. So I'm going to hand over now to my colleague Ellie just to give you a brief update on the Patient Safety Act, just a couple of minutes that you know where that's going, because it's very live at the moment and hopefully coming to commencement in the next month or two. So I'll hand over to you, Ellie, now. Thank you.
Thanks, Angela, and thanks again to Professor Doherty. Always so wonderful from a clinician's perspective to hear the kind of language that, just knowing that it exists and allowing us to acknowledge what we've been through and experience, that it's okay to have it and to experience it, as I say. So thank you again. As Angela said, I'm just going to take a couple of minutes now to give you an update on our preparations for commencement of the Patient Safety Act. It's going to be a very brief overview of our engagement with services and with Department of Health and the regulators. So as you can see from the picture there, we're really in the process of taking the Act on the road. We're out with services. Almost one part of the team is out every single day, engaging with services, delivering a presentation on the overview of the Act, and supporting with answering questions on its implementation. I'll speak a little bit more to that with the next slide. But we wanted to, first of all, probably answer what we can now answer your most burning question with what we can and know now, I should say, that we are still receiving guidance that the Department of Health is planning for a end of Q2 commencement of this Act. So colleagues will know that Q2 brings us up to the end of June. So their preparations, their planning is still that it will be commenced sometime in the next month. Of course, if we hear anything more, that will be cascaded to yourselves. And that brings me on to that next point, that second bullet point there, that all of the information that we have disseminated to yourselves through webinars. Please do go back and check out our Patient Safety Act webinars that have preceded this one today. They're all available on YouTube and via links on our web pages. For colleagues that are in the HSE, there are Health Matter articles, there are newsletters that we send to all of our stakeholders from the Open Disclosure Office, and the NQPSD, which is the National Quality and Patient Safety Directorate, also has a newsletter where myself and colleagues have produced articles that give very strong overviews of the Patient Safety Act and what steps you can be taking at this moment in time to prepare for implementation. I touched a little bit earlier there on the Patient Safety Act presentation roadshow, as we're calling it. If you want to move to the next slide, please, Mary, I'll just speak briefly to oh, I think that slide has was not been updated, but it was to give an overview of the services that we have, how our engagement with those services has been planned. We're planning all of our engagement and our communications from our communication work stream. It's one program of work which sits under the banner of the implementation working group, which is a cross-service, a group that's planning the implementation for HSE. And it has this, as I say, cross-service program of work, as I say, one of which includes planning for communication. So part of that communication and engagement program is, there it is, thank you so much, is engaging with our services in this, as you can imagine, in this planned, organized way to make sure that we are getting everywhere in the country. And if your service is not featured there, if you've not heard from us, please do get in touch. Our schedule for the so-called roadshow is being updated every day. As I say, we're out on the road every day, and we'd love to hear from you. So please do get in touch if we've not, as I say, been in touch with your service. If you have any questions, if you have any requirement for guidance, we're more than happy to support you and your colleagues in preparing for implementation. And it means that we can take your questions. If we can't answer them on the day, we can take them directly back to Department of Health, to regulators, to the State Claims Agency, who are the agency that are delivering the updates for our NIMS platform, through which you'll know notifiable incidents must be notified to the regulator. So that link in the chain for yourselves to get questions answered if we don't have the answers on the day. And just finally, I'll just say that, just further to that, we are engaging with our colleagues at Department of Health, at the regulators and at State Claims Agency, again, on a near daily basis, preparing for this implementation. So again, do please get in touch if you have any questions, and we're looking forward to getting out again, further reaching further with all of the services to get those answers to you, and preparing all the guidance documents that will be needed for implementation, and again updating our policies so that it's in line with the Act. I'll stop there and hand back to Angela, who's popped on. Thanks so much for your time and your attention.
Thanks very much, Ellie. And just to let all our participants know that we intend to give just a small update every month on, we will be doing very specific webinars on the Act, but we will do updates on the Act in our webinars in between. So thanks very much for that, Ellie. That was very helpful. So just really to finish off, just to remind people again about that open disclosure is mandatory training. We're seeing a wee bit of a fall off in training now over the last month or two. So maybe if we can get people in action again, making sure their staff have completed their e-learning module 1, which is for mandatory for all staff. And e-learning module 2 is mandatory for staff who may, as part of the role, have to engage in those higher level open disclosures, as is the face-to-face training for those people. So if you do need people trained up in your area as trainers, do link in with us in the Open Disclosure Office by emailing the Open Disclosure Office email address, and we will contact you. We are still doing a train the trainer program whilst we are out on the road at the moment doing the work on the Patient Safety Act. So we're in Limerick today, heading to Cork this evening, back up to Galway. So we're covering the West and the South well this week. So do link in with us, either in relation to the roadshow or in relation to the Train the Trainer. Just moving on there, that'd be great. So our webinar next month is going to be on the topic, extending the topic today on the topic of staff support. And we're going to have Morgan Lucy from the HD Employee Assistance Programme speaking to the topic, and again talking also about the manager's role in supporting staff. So that's on Wednesday the 12th of June, and we'll be notifying anybody who attends our webinars will be notified of forthcoming events. And you will get a copy of today's presentation, as I said before. And if you want your CPD certificate, I see a question in the chat there, do email the Open Disclosure Office and we'll send that out to you. So then in relation to today's webinar, we evaluate all of our webinars. It is an essential part of the CPD programme, and so to get your certificate you will need to complete the evaluation. It's a short evaluation, it should take you just a couple of minutes to complete. So you'll get the link to that survey out in the email following today's presentation. And really, you know, we do listen to what you say in relation to the topics that we're providing, and staff support has come up quite a lot in the feedback we've had over the last number of months, particularly with the Patient Safety Act as well about to commence, and so thank you for that. Just to also prompt you in relation to the next QPS talk time, which Eva will be delighted to hear is all about building a just culture in our health service, and that is on Tuesday, May the 28th at 1:00 p.m. So we'd encourage people to join that QPS talk time as well. And also just to finish off as well on another very important document, which is the National Consent Policy, which has now been updated to incorporate the Assisted Decision Making Capacity Act. And again, there's a link to more information on that important policy as well. And there's work happening with the team as well in relation to implementing that new policy across the system. So again, do have a look at that new policy because it is really important, you know, while we take into the concept of the Assisted Decision Making Capacity Act. So thank you for that. So just to finish up there, actually, is Eva still there? There's just a question, Eva, there in the chat. Maybe we could cover that before we finish off. And it's, how do you deal with a situation where staff are being pressurised into doing work they don't feel comfortable from a patient safety perspective?
Great question.
Or from a safety perspective, yeah, I think it is.
Yeah, great question. Comes up in our training programs all the time. I mean, this is about being assertive, isn't it? And again, I feel like I'm a repeating record here, but in an environment where there isn't psychological safety, it's going to be really hard. That's the first thing to say. But let's just say there is a degree of openness, you know, in the working environment that you're in. We like to teach a framework that comes from aviation that people really like. It's called CUSS, C-U-S-S, and it's a series of escalating steps. And it's really a prompt to use particular words to just help you assert yourself. So you start off the lowest level of all. The C stands for I'm concerned. So I'm concerned. So you might say something like, you know, I'm concerned about, you know, putting in this PIC line, for example, because, you know, I've never done one before. I haven't had the training, whatever. So concern. It's very hard for people to argue with your concern. If you don't get the response, the next level of escalation is U, and that stands for uncomfortable. So you say, I'm uncomfortable about this. I'm uncomfortable. If you still don't get the response that you want, you know, you escalate up again and you go, look, I really think this is a safety issue here, you know, about me or Mary or whatever it is being asked to do this thing. You know, I think this could be a patient safety issue. And I think safety is a real buzzword at the moment. Everybody's paying attention to that. And then the final level, the highest level of all, that again comes from aviation that people recognize, is that if you're still not getting the response you want, the final S is stop. So C-U-S-S, people really like that. So you start off with concerned. So you are going to have to assert yourself, I think, bottom line. But if you don't have the psychologically safe working environment and atmosphere, that's a whole other story. You know, it's going to be hard.
Thank you very much for that, Eva. I'd see another question from Bernd in relation to the guidance. Bernd, I presume you talk about guidance on the Patient Safety Act. So the Department of Health are doing guidance on the Act, as are the regulators. The HSE will also be doing guidance. So I presume that the private services will also be doing their own guidance around that, but I'm sure it'll be aligning to the guidance developed by the Department of Health and the regulators. But maybe link in with private services around that. I can only speak to what's happening with the HSE department and regulators at the moment, but I know that all of them are working with the private providers as well in relation to the implementation of the Act. So I hope that answers your question, Bernadette. So I think we're just going to finish off there for today. So thank you to everybody for joining, and hopefully we'll see you next month, and have a lovely day. Bye, everybody.